Wow. I don't know how you guys feel, but I'm ready. So with that, I would like to introduce two amazing people, dear friends, or co-organizers of the conference. They don't want to be introduced, but I'm just going to say it's Bob Listernick and Verena Staedtke. Thank you so much and good luck.
Well, gee, thanks, Annette, for putting me on right after Paul. I mean, how am I supposed to talk after that? So what we decided to do as a beginning is just to give a primer for those who are new to the NF community, as well as a refresher with some new information for those who've been around for a long time. So I'm going to give the more or less the first half of the talk, and oops. I don't know whether this is moving forward. Am I pushing it the wrong way? It's not moving forward. But so I'm going to give the first half of the talk once we get the slides moving, and Dr. Staedtke is going to give the second half. Can we, AV guys, can you, the clicker does not seem to be working. Maybe you'll have to advance the slides for me. So because I'm starting out with the first half of the talk, and my first couple of slides really, I always put at the end as a summation. Why don't you just move the slides forward for me? So there you go. We're going to talk about NF1, and then Verena is going to finish up with schwannomatosis and NF2 related schwannomatosis. Next slide, please. So as I said, I said this last night, I consider myself, and I'm sure Dr. Staedtke does as well, more of an educator than a physician. We spend more of our time, I believe, teaching families, teaching patients, teaching kids about NF1 and calming people down rather than educating about or treating the disease itself. So if I can say one thing to you, it's educate yourselves, and you're here today, and that's great. Educate your family physician, because I've been doing this since 1985, and the medical community has gone a long way in understanding NF and NF1 and schwannomatosis, but they have a long way to go in understanding. And most importantly, ask questions. I know as a patient, I'm actually quite a shy patient. My residents wouldn't believe it, but I don't question. I'm asking you, I'm telling you to question your physicians and educate yourselves. Next slide, please. And then another thing that came up at the CTF conference that we talked about is, what should you tell your kids? I'm a pediatrician, so I'm talking mainly about children. Don't lie. Kids are smart. Give them educationally, developmentally appropriate information. A 5-year-old, you say you're coming to the doctor to check out your spots. When they're 10, maybe you can talk a little more about NF1 or schwannomatosis related NF. You start educating them, and all our organizations have lots of great educational materials for your kids. Use them. And check your understanding at the door, and manage the emotional feelings that arise so that you understand your own feelings towards this. Next slide, please. Okay, so for those of you who have been paying attention on the websites and coming to the meetings, you know that the NF1 criteria have been revised a little bit. I'm just going to read them off and go through and talk about some of them. So 6 or more spots greater than 5 millimeters in prepubertal kids, 1.5 centimeters in adults, freckling, 2 or more neurofibromas, a 1-plexiform neurofibroma. I'm going to go through each of these as I move forward. An optic pathway tumor, 2 or more Lisch nodules, a distinctive bony lesion, and then a pathogenic genetic abnormality. When I'm realizing when I say this, when I was in medical school from 75 to 79, I learned 3 things about NF. And it was NF. There was no NF1 or NF2. Cafe au lait spots, and there was a coast of Maine and coast of California thing that we don't need to talk about. Lish nodules, like I knew what a Lish nodule was, and pheochromocytoma, which is a rare tumor, mainly seen in adults, very rare tumor. And that's all I learned. And we've come such an incredibly long way. Next slide, please. So spots. One of the first things I do when I see a new patient, because there's a lot out there on the internet, as you know, people are really worried that the number of spots has something to do with severity of disease or that the neurofibromas are going to come up where their spots are. That's not the case. And most of the spots that your kids will get, they're going to get in the first 3 to 5 years of life. And I'm told by adult nephrologists that many of you have these spots sort of fade as you get into adulthood later on in years. They darken with sun exposure. For some reason, they're extremely uncommon above the neck, and I really love to understand why that's the case. And then finally, I'm going to show you pictures. A large pigmented patch might be a clue to a neurofibroma, a plexiform neurofibroma underneath it. Next slide, please. Okay, so neurofibromas. I have some pictures for you in the next slide. When they're on the surface of the skin, when they're starting to develop, this is something I learned from my grand old physician when I was training, is something called buttonholing. You rub your finger on it and it sort of just goes into it because the neurofibroma is a little softer than the surrounding skin. Subcutaneous neurofibromas under the skin sort of feel like raw peas. They generally, and I have underlined generally, appear in the teenage years, but they could become visible earlier. But there's extreme variability. I'm sure many of you have read that women tend to notice them more during pregnancy. It's not the moment you become pregnant or the moment you become pubertal, they spring up all over the place, but there seems to be, in some people, some hormonal influence. And unfortunately, save for several specific genetic variations, we can't predict what's going to happen to you. So next slide, please. So here are some examples that you can see when they're starting. They're very flat. For us nephrologists, the clue is these little bit of hyperpigmentation, that sort of purplish hue to it. They can become sessile, means flat. They can be more globular. They can become on a little stalk. And then the last picture is a mixed picture of different types of neurofibromas in different stages of growth. Next slide, please. So I have Dr. Romo up there and Dr. Sarin, who are going to give you just sort of a preview to what's going to come in the next few days. They're going to be talking about cutaneous neurofibromas and the newer treatments for them. I'll just simply say that at the moment, there's no preventative or treatment therapy for them. But if those of you are informed, there are several studies going on using various forms of selumetinib to see whether they on topical preparations can shrink these tumors. So stay tuned to that. And I'm not going to go into great detail here because this is a bird's eye overview. They can be removed, they can be ablated, they can be cauterized, they can be frozen, and different specialists have different ways of dealing with them. And as I said, there are several trials going on. Next slide, please. Okay, so a bigger problem for me and for my children are plexiform neurofibromas. Plexiform refers to these things that they can be small or they can become bigger, and they sort of feel very like bags of worms, thickened nerves within many of them. They occur, I have down 30%. The number is probably greater if we really look. And they may occur anywhere in the body, both on the outside and the inside. They're generally present in infancy. We tend to think of them as congenital. In other words, you're born with them, even if you really can't see them initially. Clues to their being involved, and I'll show you pictures. There can be a pigment, like a little pigmentation over it. There can be slightly purplish. There can be some hair over them, usually a thickened skin or some fine hair. Next slide, please. So here's an example. Um, the pigmentation is a little greater. There's some hair there. And this is one of my big bugaboos as a pediatrician. I have no doubt that this picture came from somebody who went to a surgeon or a plastic surgeon and said, hey, I don't know what this is. So surgeons don't examine the whole body. They examine they examine the area that you come in to complain about, and the kid got a biopsy. No reason at all. And I have numbers of kids who have gone to various different doctors, say, hey, I have this growth on my body before they're diagnosed with NF1, and get biopsies. And then, of course, some of them get really not great looking scars because of it. And it just really makes me mad. Next slide. And here's an example of one on the back that once again shows the pigmentation and the hair above it. Next. I put this slide up. This is mainly for medical students. I mean, this is a plexiform neurofibroma. It's easy to miss because it's sort of wrinkly, and it's very soft. And I remember when a resident, I should say, went into the room and examined this patient who was a teenager, first diagnosis of NF1. And I went in the room to examine, the kid's in a gown, but he has his sneakers on. I take the sneakers off and I see this. Never complained. He'd been wearing different size shoes his entire life. And they just thought that's just sort of the way it is. So one of the things I make sure I teach residents and medical students, examine the whole body. Next, please. All right. So I learned this from Vic Riccardi. Many of you know is the grand old man of NF. One of the things he taught me very early on is plexiform neurofibromas are present at birth or become clinically manifest in the first several years of life, at least the ones on the outside. So what that means is if you have a child who's 3 or 4 years of age, 3 or 2 or 3 years of age, and we don't see anything, then you don't have to worry, at least on the outside, that your child is going to develop plexiform neurofibroma on the outside. Stay tuned for studies we're going to be doing looking at whole body MRI. You're going to hear more about that later on, about its use and the use of selumetinib as a preventative measure for these growing on the inside as well. So that's something you'll hear about hopefully in the next year. Next, please. The growth rate is very variable. Some of these tumors just stay quiescent, stay the same, and some of them grow slowly, some may grow rapidly. It really depends. I can't say at the very beginning when I see a 2-year-old with a plexiform neurofibroma, what's going to happen. We tend to think that the rapid periods of growth are in early childhood or in puberty, but it is variable. Next slide, please. You can imagine, and I'm spending a little time on this because this is one of the big sources of morbidity in kids. You can imagine that it can be a cosmetic issue. They can cause problems if we have kids who have the whole leg is covered with plexiform neurofibroma, or they're on the inside and they block, bladder or bowel. I already talked about unnecessary biopsies. Next, please. Once again, here's an advertisement for, I believe it's tomorrow. Miriam Bornhurst is going to talk about the selumetinib story. And we've heard this many times about how great, what an innovation this has been. Generally, you can't remove these in their entirety. They have little fingers that spread out, but there's certainly many people can benefit from surgery for them. But the optimal time is not always clear for an individual child. Next, please. Okay, I mentioned Lisch nodules, and I'll simply say that these are little bumps in the iris and the colored part of the eye. They don't cause any problem at all. They're specific for NF1. They're age dependent. The older you get, the more likely you are to develop them, and they're just a sign that help us make a diagnosis in confusing cases. They don't cause any impairment of vision. Next slide, please. And that's just an example. Usually they're not as easy to see in the naked eye, but in this picture, you can easily see the brown bumps. Next, please. And that's just a closer look. The ophthalmologists use a slit lamp. That's the machine where you put your neck into it and they can see these very easily. Next, please. Okay, so once again, here's an advertisement for Dr. Rob Avery, who is the maven of optic pathway tumors. He's going to give a superb talk, I know, tomorrow at cutting edge stuff about what's going on. So I'm just going to give you an overview. If I were to do an MRI scan in every child who has an optic, who at the time of diagnosis of NF1, about 15% of them will have an optic pathway tumor. But of those 15%, only half will ever cause symptoms. So the true incidence is about 7%. They're a complication of young kids. So for the most part, if your child is 8, 9, they're unlikely to develop a symptomatic optic pathway tumor. There are rare cases where they do spontaneously regress later on in childhood. Next slide, please. Just to give you, I don't have a pointer, but you can, I was drawing this in my stick figure form for somebody yesterday. You can see the nerves and anything that affects the nerves before what's called the optic chiasm, where the two nerves gain together. Anything before that affects vision in that one eye. Anything at the optic chiasm or behind it may affect vision in both eyes. Next slide. And this is just a picture of a normal CAT scan with normal optic nerves, and this is the same child 15 months later. Next slide. Next slide, please. Who had well, back one slide. Just that's what it was like 15 months later. So this is unusual, but it definitely happens. Next slide, please. One of the things that I want to tell you, and I tell physicians all the time, kids don't complain of vision loss. They don't. This is why your children need to have yearly eye exams. I can't tell you how many times that I've had, I remember one child, he was 4 years old and he dropped a Cheerio on the floor, and his parents saw him bend down and his eye is literally an inch above the ground. They had no idea that he had significant vision loss until that point, which is why, and I think Verena will talk about it later on, but kids need yearly eye exams and in their NF1 holistic care. Sometimes, not commonly, a tumor behind the eyeball can push the eyeball out. That's called proptosis. And then something that I am very attuned to, and hopefully, and most pediatricians are attuned to, is the early development of puberty. And the first sign of that is not the development of breasts, not the development of pubic hair, but accelerated growth. That's why most of you who have kids, your pediatrician should be keeping growth charts. And a clue, in about 30 to 40% of kids who have these tumors, the first clue can be an accelerated growth. And that's because the chiasm, that area where the two nerves come together, is right near the hypothalamus, which controls the pituitary gland and all the hormones. Next slide, please. Next slide, please. So what happens if your child has an optic pathway tumor? Progressive disease is in the minority of patients. It's not a sentence. Your child's not going to go blind. It's not, and treatment is really only indicated if there's progressive disease. In the old days, and I'm saying old days, maybe less than 10, over 10, 15 years ago, the focus was on the tumor. Now the focus is primarily on the vision. The tumor may grow, but if your vision stays the same, most NFologists are not going to recommend treatment. It's very individualized, but the focus now is on the vision. And the treatment is chemotherapy, not surgery. Next slide, please. And that's just to show you what a growth chart looks like of accelerated growth. And just so you know, there is treatment for that. Even if the tumor doesn't need treatment, we can treat the accelerated growth, so that, because the ultimate end of that is your child will be shorter than he or she would normally have been. Okay. Oh, you got it working now? Okay, the green one, right? Yeah. It works. So I'm nearly done giving Verena her time. So one thing that I want to bring up, because this is something that has been found a number of times, is brain tumors in the brainstem. The brainstem is the back part of your brain that's going down your neck. The reason what you should know is that brainstem tumors and optic pathway tumors, for that matter, in NF1 are very different than tumors in children who don't have NF1. In children who don't have NF1, these tumors keep growing and growing and growing and always need treatment, almost always need treatment. In NF1, we were talking, we have numbers of kids who they found these tumors for whatever reason, either it was an incidental finding or something, and the tumor just stays there and doesn't do anything. That doesn't mean it won't do something, but more often than not, it doesn't do anything. So once again, just because it's there doesn't need treatment. And I'll just give a segue to saying, this is why everybody with NF1 should be treated in a multidisciplinary clinic by NFologists who know about NF1. Because I can tell you many times where in less informed clinics will jump in and treat either of these conditions when it's not necessary. Finally, I'm going to talk a little bit about bone disease. One of the defining criteria, I'm sure many of you know about tibial dysplasia, bowing of the tibia or any long bone, and sphenoid dysplasia. I'm going to show you a slide of that in a minute. And Dr. Larson, tomorrow is going to talk about all this stuff as well in much more detail than I could ever. Tibial dysplasia occurs in about 3% of kids with NF1. The goal is to prevent a fracture. The goal, so you'll see a number of kids with NF1 who have this wearing like a shin guard, an orthosis to prevent any trauma to the leg. What we're trying to avoid is a pseudarthrosis, which means false joint, because that, as you can see, on this child on the slide on the left, it's broken, and it looks like there's another knee there. That's where the treatment with bone grafts and intramedullary rods to stabilize it comes into play. A whole different thing than in the era 30 years ago, where you saw many adults with NF1 have amputations because of this. That's a rarity now, rarity in NF1 children. And then the sphenoid wing is the back wall of the orbit, that green area. And so what that means, if the orbital wall is missing or not as well formed, you can have free communication between the brain and the orbit, and sometimes brain contents can herniate, can go into the globe, and that may need, and into the eye socket, and that may need to be fixed. Very briefly, because I don't want to take up too much time. How are we doing on time? Scoliosis. There are two types. There is one that you're born with, where their bones are abnormal, and there are ones that you develop that kids with NF1 don't develop. And that's why it's important for your physicians to monitor your children's back as they start going into puberty. And here's an example of what scoliosis looks like, and that's a dystrophic scoliosis. And I think this is my last slide. The vascular complications, are you okay? Vascular complications of NF1, any artery in NF1 can be abnormal. The ones that you'll hear about or your physicians will mainly talk about are either the artery leading to your kidney, and that can lead to hypertension, which is why your physician should take blood pressure of your child or of yourselves every time they come to clinic, or blockage of the blood vessels going to the big arteries in the brain, which can lead to stroke. So that's another thing we would monitor. And I'm going to stop there and let Dr. Staedtke keep going.
Excellent. Thank you. Certainly a great honor to be here. And we are going to continue with cognitive problems, which are a problem in a large portion of patients. And this is because neurofibromatosis, which is rendered dysfunctional in patients with NF1, is very important for brain development. And this causes patients with NF1 to be at increased likelihood to demonstrate lower, yet often still normal scores on intelligence tests, and to be more likely to be diagnosed with a learning disability. In fact, 75% of children are diagnosed with a learning disability, which really is the inability to acquire and use academic skills. And this can involve verbal and nonverbal areas. A large portion of children will also have social difficulties. A fraction of those will be diagnosed with autism, but the true number of autism among NF patients is actually unknown. The next slide shows an overview of common problems we see in kids with NF1. Those include delayed language skill development, problems with visual spatial and visual perceptual skills, which is the inability to follow objects in space and object recognition. We see problems with motor and fine motor development. And one thing you might experience is that your child has difficulties to learn how to tie the shoes or ride a bike. We see problems with executive function, which involves things like time management, poor problem-solving skills, or not thinking before you do things. And then we see big problems with attention and memory. And there have, in fact, only been very few studies out there that looked at the academic achievements of children with NF1, but those that did showed consistently significantly lower scores, also raising the possibility of really an unidentified educational need here. So really, what should you do if you suspect learning problems in your child? The first thing is probably to talk to your child to see what type of problems they experience. You should also talk to the teacher to see how they perceive your child in the classroom, and they may give recommendations on strategies how to improve that. If that does fail, the next step would be testing and to understand the weaknesses and the strength of a patient. And there are two options when it comes to testing that can be done through the school counselor and neuropsychologic testing. Testing done through the school counselor is usually more focused and aimed at understanding the educational needs, versus the neuropsychologic testing is a more comprehensive testing that gives broader recommendations that might be helpful to your child in and outside of the school setting. Public schools in general have two tracks to support the educational need of your children. One is the 504 plan, and the other one is the individualized education plan, or IEP. The 504 plan is typically implemented in the classroom and actually does not require testing. The individualized education plan, the IEP, does require testing in the diagnosis of a learning disability. And I'd like to refer to a talk which is given by Karen Walsh, who is a neuropsychologist that is focused on helping children with NF1, which is going to happen later on today, and she'll go into much more details about that. One last word on the neurocognition is that attention problems are very, very common with and without hyperactivity. The combined type is the most common type, and they frequently coexist with other learning disabilities. And although in some children, the problems can be very obvious, for others, they may be subtle, yet very significant, and only formal testing may help to diagnose those. If diagnosed, in general, kids should be treated with a combination of either medications, behavioral therapy, counseling, and educational service to help and improve their academic successes. There is currently no NF1 specific therapy available. However, we have noticed in children undergoing MEK inhibitor therapy for plexiform neurofibromas that they might show encouraging improvements in neurocognitive functioning. And so therefore, I'm hopeful that in the future, there might be soon to come on that area. We also see an increased risk for cancer. In fact, patients with NF1 are 10 times more likely to develop a cancer, and about 40% of patients will be diagnosed with a cancer during their lifetime. Malignant peripheral nerve sheath tumors, or MPNSTs, which develop within the plexiform neurofibroma, as you can see in the picture there, and gliomas are the most common types of cancer. They occur occasionally in children, but are much more frequent in adulthood. Over the recent years, we have also started to link other cancers to NF1 that we were previously not aware of. And those include breast cancer, certain types of leukemia, ovarian cancer, several rare sarcomas, and even melanoma. The other thing that we have learned over the last few years is that patients in patients with NF1, cancers are occurring at a much younger age, and they're more likely to die from this condition. And the reason for this is really unknown. It may be that the cancers are diagnosed at a later stage when it's more difficult to treat, or the treatments are less effective. But given the poor prognosis, really vigilance from patients and clinicians is needed to thoroughly look and evaluate new symptoms. There are specialized cancer screening guidelines that exist specifically for NF1. One of those examples is breast cancer, for example, that was recently changed, in which women are now screened at the age of 40, compared to at the age of 30, compared to women at the age of 40 with standard risk. And Dr. Shekshern is going to talk about these new guidelines tomorrow. As many of you know, NF1 is a single gene disorder that affects the RAS pathway activation, which is really a key regulator in normal cell growth and cancer development. It is inherited in an autosomal dominant pattern, and what that means is that a single copy of the disease gene is sufficient to cause the disease, and thus there is a 50% risk for children to inherit this condition from a parent. It does not skip generations, so the penetrance is full, and about 50% of the patients we see in clinic are the first one to be diagnosed with this condition. One of the most challenging facts in NF1 has been the fact that the expressivity, which is the severity of a clinical symptoms in patients that share the same genetic change, is highly, highly variable. And this makes it really impossible to predict which complications and which symptoms a patient may develop in the future. And this is even true among family members that share the very same genetic change, where symptoms can vary from very mild to very severe. Genetic testing is available for patients to diagnose NF1, and it is very sensitive. It can detect over 95% of patients. However, if a child fulfills the diagnostic criteria, genetic confirmation is usually not needed. On the other hand, it can be helpful to confirm a suspected diagnosis before the clinical diagnosis is possible. It can help to differentiate NF1 from other conditions that look very similar. One of these things is Leach's syndrome, for example, which only presents with pigmentary changes such as cafe au lait spots and freckling, but these patients are not at risk for tumors and don't need to see us in clinic. It can also be very helpful for patients that have unusual symptoms in NF1, but again, it does not predict symptoms or complications, perhaps with a few exceptions, which I'm shown here. The very first one on the list reads microdeletion, and this is when a large part of the gene breaks away. Children that carry this genetic change usually often have a more severe clinical course with more tumors, a higher risk for malignancy, and also more cognitive impairment, among several other problems. If you go down the list to the third, these patients typically have very mild symptoms, typically just cafe au lait spots and freckling, and those patients are typically not diagnosed with tumors. So I think this contrasts the variability we see in patients very well. And then in terms of the clinical evaluation, as Dr. Listernick mentioned, it's very important we see children regularly in clinic. Each child should have a physical examination, which includes also measuring of blood pressure, measuring of growth, a pain screening, a skin exam to look for any masses, and a neurologic exam. Screening for developmental, neurocognitive, and school problems is also important. As we just heard, they're very common. Each child should be regularly seen by an ophthalmologist, usually once a year, sometimes more often. But one thing we actually do not need is routine neuroimaging. So routine neuroimaging in patients that don't have symptoms is not recommended. However, if symptoms evolve or signs start to come up, then imaging might be needed to look for an underlying pathology. As I said before, and as Dr. Listernick mentioned, it's very, very important to see patients regularly in clinic. And this is because symptoms change as kids grow up. And this slide shows the symptoms in relation to age. So we frequently see cafe-au-lait spots, bony dysplasias, and plexiform neurofibromas developing early in life. They're often diagnosed shortly after birth or even at birth. Learning disabilities and optic pathway gliomas are typically diagnosed in early childhood. And then in later childhood, we often start to see scoliosis, cutaneous neurofibromas, or brainstem gliomas. And then cancers, as I mentioned before, is typically a phenomenon we see more in adulthood. The next slide shows the timeline at a little bit more detail. And here I want to point out that plexiform neurofibromas are typically congenital, which is different in optic pathway gliomas, which are not congenital, but they develop between the ages of 2 and 8. And what this slide also shows us is that they might be windows for us, windows of opportunity to actually put treatments in place that may prevent the development of certain types of symptoms. And this is in fact a large focus of research at the moment. So with that, I actually want to switch from NF1 to another condition, which is NF2-related schwannomatosis, formerly known as neurofibromatosis type 2. This condition was recently renamed, and the clinical diagnostic criteria were updated. And the renaming was intended to really reduce misdiagnosis, to better reflect on the clinical symptoms these patients may have, and to guide clinical care more appropriately. And I think with the renaming, what becomes clear is that NF2-related schwannomatosis is absolutely distinct from NF1. It has a different gene, a different chromosome, and very different symptoms. It is rarer than NF1, but in fact, it is more common than what we used to think. About 1 in 25,000 patients is affected by this. It is caused by disease-causing variants in the NF2 gene, which is located on chromosome 22. And the NF2 gene produces myelin, which is really a cell membrane regulated protein that can act as a tumor suppressor. One thing we also know about the disease is that the symptom presentation hugely differs between children and adults, with adults experiencing hearing loss, ringing in the ear, and imbalance. This usually starts around the age of 22. Children, in contrast, present with very different non-hearing based symptoms, typically starting around the age of 6. And I want to mention here that the earlier patients show symptoms, the more likely it is that the cause is severe. Typical symptoms we see in children are, for example, skin tumors, eye findings, or seizures. One important thing about this condition is that patients have really multiple tumors and multiple tumor types. On the upper left, you see vestibular schwannomas, which are tumors on the 8th cranial nerve. On the upper right, you see that patients may develop one or many meningiomas, and those can really occur in any spot in the brain and cause problems. Patients might experience spinal ependymoma, which is shown in the lower left, and patients may also experience non-vestibular schwannomas. And those are essentially schwannomas at any location except for the cranial nerves. And although the histology, the nature of these tumors is benign, they can cause many, many problems, and therefore the clinical cause is not benign. Recently, the clinical criteria were updated for this condition, and Dr. Caleb Yohe is going to give an excellent talk early on this afternoon about this. So I only want to briefly tell you here that bilateral vestibular schwannomas or features of schwannoma, meningioma, ependymoma, along with positive genetic results are sufficient to establish the diagnosis, in addition to major criteria, which are essentially unilateral vestibular schwannomas parent with this condition, 2 or more meningiomas, or a pathogenic variant in blood, can make the diagnosis, or the combination of 1 major and 2 minor criteria, and the minor criteria being ependymoma, a single meningioma, and schwannoma, along with ocular findings, which I'm going to go in a little bit later. Vestibular schwannomas are really the hallmark of this condition and the major cause for clinical problems. And these slow-growing and benign tumors grow essentially on the vestibular nerve, which, as you can see in the cartoon, connects the inner ear to the brain. Branches of this nerve are involved in like hearing and balance, and pressure from the tumor on the nerve will cause hearing loss, dizziness, ringing in the ear, or imbalance. If the tumor gets big enough, it may push against other brain structures, as you see in this cartoon, and may lead to problems with facial movement, visual problems, problems with swallow and speech, or even interfere with vital functions. This again is a picture showing you bilateral vestibular schwannomas, which is the hallmark of this condition. You see those big bright masses in the middle of the picture, and normally the vestibular nerve is just barely visible on the MRI. So how can we measure the impact of a tumor on the vestibular nerve? One way to do that is like doing audiometry or hearing testing, which some of you here might be familiar with. And with this test, we have the ability to assess each ear individually. The red line represents the right ear, and the left line represents the blue line represents the left ear. And the way how those curves fall within the diagram gives us the degree of hearing loss. Also part of this exam is a more functional assessment, what I can do with my ear. And this is called the speech perception or word recognition score, which is a percentile score. And both of these scores together give us an idea what the degree of hearing loss is and what the functional status of the ear is. And this is very important when we think about managing and treating these lesions. The goal of treatment and management is really hearing preservation or restoring hearing whenever possible. And as such, we're able to monitor tumors when they are small, not causing any problems and not pushing against other brain structures. However, in patients that have large tumors or tumors are in dangerous places where we cannot leave them alone because that might result in compression of the brain, they often have to be removed. The surgery is sometimes able to save existing hearing if tumors are small, but surgery is rarely being done to make hearing better. There are non-surgical approaches that have come up over the last year that are able to extend a patient's hearing ability. And one of those is bevacizumab or Avastin, which is a monoclonal antibody against vascular endothelial growth factor. And this is used for growing vestibular schwannomas and new hearing decline. And it has been shown to induce tumor shrinkage and even bring back hearing in a subset of patients. This kind of treatment works typically really well in adults, but we have not seen big success in children, unfortunately. Aside from that, there are several other chemotherapies and other treatment options that are sometimes being considered depending on the specific situation of a patient. And I'd like to refer to an excellent talk later on this afternoon done by Francis Creighton, an ENT, and Dr. Blakely, a neuro-oncologist, to really discuss the complexities of medical and surgical approaches to these type of tumors. We also have rehabilitative options available for our patients to mitigate the symptoms these tumors might cause. For example, for dizziness and imbalance, vestibular rehab can help to reduce those symptoms. For patients specifically with hearing loss, speech reading and sign language is a skill that can be learned. For patients that still have functional hearing, but it's not quite normal, hearing aids can be used to make sound louder. If patients have no hearing and no nerve in one ear, but one good ear, sound can be converted to the good ear using bone conduction. If you have no hearing but an intact nerve, cochlear implants can often be used. And if you have no hearing and no nerve left, auditory brainstem implants are sometimes being considered. And I'd also like to make another note here of an excellent panel discussion that is going to happen tomorrow, led by Heather Thompson, Tina Childress, and Matt Hay, to discuss rehabilitative option in NF and communication strategies for our patients with NF2-related schwannomatosis. Aside from tumor manifestations, we often see also eye symptoms in those patients, and strabism is one of the more common ones we see particularly often in children. This is when the eye muscles don't work well, and as you see on the upper picture, where the eyes are not perfectly aligned straight. This can be the very first sign of NF2, and it's important to have those children checked out by an eye doctor because they can help to establish the diagnosis. Aside from strabism, we often see certain subtypes of cataracts, those ones that present often in younger patients, less than 40. And normally when we are born, our lenses are clear. But in patients with NF1, as you can see here in this picture in the second row, the lens has a wide opacity. And this is very important to catch this early because there are treatments available ophthalmology can do to prevent vision loss. Other things we see are sometimes there's something called epiretinal membrane, which is the growth of a membrane on the top layer of the retina. And this is essentially, so, and what that does is it elevates the retina and it makes it kind of not smooth. And that's a big problem because over time, this can also advance into the vision center and patients can get reduced vision from that. Similarly, retinal hematomas, which is the lowest image, it shows like a photograph of the retina, which with a brownish kind of elevated spot. And this is a spot that occurs in a number of patients. It is not cancer, but nonetheless, over time, the spot may progress and again may result in vision loss. Skin findings are also common in those patients. In fact, 70% have skin findings, which can actually look very similar to NF1. So we see caveolé spots and skin tumors, but those are much lower in number. However, about 1 to 2% of patients have actually more than 6 caveolé spots, and this can sometimes lead to misdiagnosis, particularly in young children. So this first image here that you see is a patient, a young patient of mine who has actually NF2, but he presented at a very young age, at the age of 3, and was initially wrongly diagnosed with NF1. Patients with NF2 related schwannomatosis can also have hypopigmented macules, which is shown in the second picture. And the same hypopigmented macules, similar ones, can be seen in NF1. So it's very difficult often to distinguish this. Skin tumors can present with plaque-like lesions, as you see in the first row, the third and fourth picture, with hair and without hair. And then about 95% of patients develop cutaneous schwannomas. And those schwannomas are inside the skin. That means when you palpate the skin, they're moving along with the skin. So most patients will only have a few of those tumors. Only very few patients have a lot of them. So that is kind of a difference to NF1. In terms of genetics, genetic testing is available for patients with NF1-related schwannomatosis, and it is sensitive. It can detect 60 to 90% of the cases. The condition is also inherited in an autosomal dominant way, just the very same like NF1, meaning one copy is enough to cause this condition. About 50 to 60% of the patients we see in clinic are the first one in the family to be diagnosed with this condition. And about 30% of those non-familiar patients have something that's called mosaic, which means not every body cell carries the faulty NF2 gene. Within a family, the disease severity appears to be very similar, but there's great variability between different families. And in contrast to NF1, NF2 has a strong relationship between the type and the site of the pathogenic change. And that correlates very much with symptoms and outcomes patients are having. For example, genetic changes that lead to a truncated or shortened version of the protein, they tend to have a more severe cause with more severe problems and worsening of functional outcomes versus changes that lead to either no protein at all or complete but an incorrectly made one. They tend to be milder. And also patients that have mosaicism tend to have a milder disease course. The clinical evaluation for these patients is very complex and involves a multidisciplinary care team. Usually patients need to get a physical exam, a skin exam to screen for tumors, and the neurologic exam is very important to find new problems. Patients also need to see the eye doctor regularly to prevent vision loss, as we saw those numerous eye symptoms, and patients need to be seen or need to undergo audiograms so we can keep an eye on how the hearing is working long term. Patients usually undergo serial MRIs of the brain with thin cuts through the auditory canal and the spine so we can monitor tumors long term. The goal really of the clinical evaluation is to preserve function for as long as possible. Also in this conference, you will hear a lot about new approaches in the lab, new gene-based approaches that might be able one day to have new treatments for this condition. And Dr. Meyer's lab is going to talk about some of these approaches tomorrow. We have new mouse models available in the laboratory to better study and understand this condition. And then there are initiatives like the CDF-led initiative Synodus that is dedicated to finding new treatments for NF2. So there's lots of hope there. And with that, I'd like to proceed to my last section, which is other schwannomatosis. So aside from NF2-related schwannomatosis, there's a number of other types that exist. And they are classified essentially by the disease-causing gene or the lack thereof, and the clinical syndrome they cause, the schwannomas. These other schwannomatosis are very, very rare. They're usually characterized by multiple painful non-cutaneous schwannomas that occur on peripheral nerves, spinal roots, and cranial nerves. Other tumors can be associated with this, but are actually quite rare. Usually this condition is found in adulthood. Occasionally, we diagnose a child with that, and this is mostly done based on family history, which is positive in about 20% of the patients. This slide shows the two most common subtypes, LZTR1 and SMARCB1, and they are responsible for the vast majority of familiar cases. They have an incomplete penetrance, and what that means is they can actually skip generations. About 20% of the sporadic cases are also caused by LZTR1. And this kind of condition is very tricky because patients have higher pain and a worse quality of life. Both of these genes are also related to other tumors and cancers. And there are probably many more genes that can cause this condition that we don't know about yet. So there may be advances in the future to come. Also here, clinical criteria were updated, and I'm just saying briefly that one confirmed schwannoma or nerve tumor along with positive genetic testing in blood or finding the genetic change in 2 different tumors is enough to diagnose that. But then genetic testing is not needed really to make the diagnosis. So if testing was not performed or negative, you can make the diagnosis if you have 2 or more of those schwannomas on imaging that are not in the skin. And one of these schwannomas need to be proven under the microscope to be a schwannoma. So this is an overview of where tumors can be. As I said before, 100% all people with this condition have schwannomas along the peripheral nerves. And the first image shows actually a schwannoma on the nerve in the arm, and the second one, a schwannoma on a nerve in the leg. A huge number of patients also will have schwannomas in the spinal roots, which can occur in one or multiple levels and cause lots of problems there. A small portion of patients will have schwannomas on the cranial nerve. This is an example of a schwannoma on the trigeminal nerve. And then some patients, about a third, will also have schwannomas on the skin. And these schwannomas are different than the NF2-related schwannomas because these schwannomas sit under the skin. So the skin moves freely above the tumor. So this is one sign to distinguish them. The clinical evaluation for patients is a good, really history, family history, reviewing the pathology under the microscope, and then looking at the skin and screening for these masses. The neurologic exam is important because they can all lead to deficits. A brain MRI with thin cuts through the auditory canal, a complete spine MRI, and a focused MRI might be needed. And the management then of these lesions is really focused on pain management. And this is done with pharmacologic and non-pharmacologic therapy, and in certain circumstances with surgery, okay? And so the big take-home point after this very long talk is really that each patient with any of these conditions needs to be regularly, yearly if possible, seen in a specialty clinic where physicians are familiar with this condition, where there's easy availability of subspecialties. And it's important to educate like your family physician, your community about these conditions. And with that one, I want to thank everybody for listening. And I'd like to invite up two of my patients that have come all the way from Baltimore to be here with us, which is Dominic Perrotta and Cameron Rodriguez. You both can perhaps take a seat up there. And those are really fabulous patients. I came to know them when about 8-9 years ago when they were much younger, and they have really grown up to be terrific individuals with big plans and big dreams. Both of their ways in the disease have not been easy. Both have had lots of therapies they had to endure. And I'd like to invite each one of them to perhaps give us share a little bit of information about them. And yeah, you can talk directly in the microphone if you want.
My name is Dominic Perrotta, and I have NF1 with the microdeletion, and I'm a junior in high school. And I just thank you all for letting me be here.
I am Cameron Rodriguez. I have NF2. I was diagnosed at 10, and since then, it's been a wild journey. Thank you for having me.
So, we are very thrilled to have you guys here. And I think both of you have actually endured a lot of different treatments. And I think perhaps starting with Cameron, what I think people might be interested to know is, because you were diagnosed at a very young age, really, with this condition, how does the NF2, how do the symptoms you're having affect your daily life, and how do you deal with that? How do you cope with that?
Well, honestly, it hasn't affected me too bad. It definitely changed school with, bullying, but that's just how kids are. I would like to say that I'm a lot like everybody else. I live my days how most people do. I don't go outside, but that's just teenager stuff. Honestly, it hasn't skewed my life path too bad.
Okay, that's very good to hear. Okay, and Dominic, I think one thing I want to share about Dominic is that Dominic has had many complications from NF1. He's, similarly to Cameron, had to endure lots of treatments, different treatment, but both boys really had to have lots of treatments. And Dominic is somebody that's always very positive. And I think what would be interesting to know is, like, Dominic, how do you motivate yourself to take your medications every day? And what advice can you give others to really soldier through those therapies like you have done?
How I really motivate myself is I don't want the tumors to grow back or cancer I had to come back. So I just motivate myself to do that. And advice I would give is, yeah, you may have NF, but it shouldn't define who you are. And I just put my faith in God, and it helps me through it. Hold on, along with listening to my doctors and my parents and friends, just help me through this tough time.
Excellent, excellent. And Cameron, you also have like such a positive attitude. You've had that throughout all these years. How do you motivate yourself?
Well, honestly, a lot of the time I forget my medication because I am very easily distracted. I end up taking it, but not on time. I keep going forward because of the people who've been around me throughout all of this. I don't want to let anybody down.
Okay. And Dominic, what do you think are your biggest challenges?
Some of my biggest challenges are like social interactions because I can be too literal and that can be kind of awkward. Some physical limitations because I just can't keep up with my peers. I try my hardest, and then some emotional struggles. I just can't de-escalate a situation, but I've had help with therapy and my parents
Super.
to get through that.
Excellent, excellent. I think one thing I want to share about Cameron is too that he is currently a senior in high school. So he is looking into his future, applying to colleges. And I think it would be very interesting for us to know, what are your plans for the future? And do you think NF2 is affecting those?
Well, my goal is to major in biological sciences, more specifically bioengineering. It's just science has always encaptured me, and with what I have and who I am, I feel like it'd be really interesting to get to know more about what I've been going through and researching NF on my own.
Yeah, I think that is truly very inspiring. Very great, great. And Dominic, what's your dream?
I like to be in like film industry, like doing behind the scenes stuff, filming, editing, directing maybe. I just want to do like all the behind the scenes stuff.
Excellent. Very good, very good. I think we are out of time. We are very happy and honored that everybody is here and followed our talk. And I think with that, we can close the session. If there are any questions, please come up.
But I think
Oh,
we're a
sorry.
little behind. So anybody come up afterwards in the breaks, talk. If you have questions, you can ask me or Dr. Staedtke.
Yeah,
We're
here.
happy to talk to you.
Great. Thank you.
And Hoover. Connie's telling me don't forget Hoover.